Gilbert Welch, a general internist at the White River Junction VA Medical Center in Vermont, and a professor of medicine at Dartmouth, and also a professor of public policy and business administration at Dartmouth. Welcome. Thank you for coming.
Thank you. Thank you all for being here, and I hope everybody can hear okay. And I'm going to start by talking about my favorite subject, myself. 58 years ago, I was born a privileged white child. It is what it is, and this is a picture my mother took on Kodachrome. Some of you will remember that technology. And I know there may be some people with a little bit of clinical experience in the room, and when they look at that child, they immediately notice there's some things wrong. The child is clearly overweight. Probably has toddler hypertension. Hyperlipidemia for sure, glucose intolerance. And then just look at that face. Pediatricians have a name for this. They call it funny looking kid. Probably have a bunch of single nucleotide polymorphisms, a couple of genetic variants, maybe even a frame shift mutation. But the real question is what's going on in there? What is that? Could that be an early abdominal aortic aneurysm? Boy, I'm glad I was born 58 years ago. This is today. This is Chicago O'Hare Airport. I'm sure many of you have changed planes there. And this is an ad from IBM, International Business Machines. And in full disclosure, I'm a shareholder in IBM, although you're looking at Macintosh-produced images. But this is their idea of the future, medical histories that alert doctors before patients get sick. And I suggest to you this is something we've all sort of assumed that's a good thing, right? Alert doctors before patients, that's a good thing. But I'm going to ask you to think hard about that in the course of the next hour. By the way, this is going everywhere now, right? Here we are offering wellness plans with convenient payment options. You may not notice this is actually a vet in Geneva. That's where we were driving across the country to go to Bozeman this year. My wife found this and said, you got to take a picture of it. So it's all over the place, right? Let's get involved in well patients. So the title of my talk is Overdiagnosed, Making People Sick in the Pursuit of Health. And what we're going to do is really question a widespread presumption, and that is that the best strategy to keep people healthy is through early diagnosis. Now, a couple disclaimers before I start. First, the views expressed here do not necessarily represent the views of the Department of Veterans Affairs or the United States government. This could be said of many of my views. And the second is, because of my interest is to give you a sense of the breadth of the problem, this will be a cursory review. So, think of it as a mile wide and an inch deep. And those of you who want to ask questions about areas in more depth, I'd be happy to talk to you. I also have a book with the same title with my colleagues Lisa Schwartz and Stephen Woloshin. And I have another book, Should I Be Tested for Cancer? Maybe Not, and Here's Why. In this era of financial entanglements, I want to be clear, I have no financial interest in either of these books. All the royalties go to local charities in the upper Connecticut Valley. But of course I have a strong professional interest, and if you have further interest in knowing more about why I say what I say, I would be happy if you were to read it. So let me give you an overview of what I'm going to do today, and those in the back, there are certainly seats up here if you'd like to sit down. If you'd prefer not to be close to me, that's okay too. I want to talk about first, what is overdiagnosis? I want to define the term. Then I'll go through some mechanisms by which overdiagnosis occurs. And there are four of them I'll touch base. One is we change the rule. We refers to the medical community, physicians, etc. We are able to see more. We look harder. And we stumble onto things. And then finally, we'll move forward. Let's start with what is overdiagnosis. It is the detection of an asymptomatic abnormality or condition that either A, will never progress or will in fact regress, or B, will progress slowly enough that the patient dies of other causes before symptoms appear. So the key idea here is this asymptomatic. The patient doesn't experience the problem and will never go on to experience the problem. Now note, overdiagnosis is typically a side effect of what we've been taught to believe is the right way to practice medicine. That is, detect and treat disorders before they cause problems. We only get into this problem when we try to get ahead of symptoms. Now I want to be clear, this is not easy. There's a conundrum. Clinicians in the field can never know who is overdiagnosed at the time of diagnosis. It's not like patients have the word overdiagnosed on their heads. It's not like it's obvious who's over. Oh, we have some clues. Overdiagnosis is only confirmed in an individual if that individual is A, never treated, no intervention is done, and B, goes on to die from something else. And that doesn't happen very much. Our tendency is to intervene on everybody. Once we make a diagnosis, we tend to intervene, thereby producing the major harm of overdiagnosis. Treatment that cannot help because there's nothing to fix, treatment that can only lead to harm. And all of our treatments have some harms. Clearly some have more harms than others, but all of them have some harms. So how did we get here? What's the genesis of this problem? Well, I think the genesis really is in the detection and treatment of hypertension. And when I'm in a global health community or a public health community, I'm always nervous. Here I am raising questions about treating high blood pressure. Isn't that one of the most important things we do? Yes, it is one of the most important things we do. But it's also where the problem begins to happen. Let me start with why it's so important, and I'll share with you a classic randomized trial, the 1967 VA cooperative study of hypertension. I'll go through the design of this study. The patients were recruited, and the entry criteria, they were all men, because that's what the VA treated at the time, with diastolic blood pressure elevation in the hospital. They had to pass a test of outpatient compliance, a test I'll come back to in a second. And their average outpatient diastolic blood pressure was 115 to 129.
That's not very high.
It's the bottom number, folks. That's like really, really high. Most people think that that's a systolic blood pressure. That's the diastolic. Yeah, that's high. So whoa, this is really high blood pressure. They're going to be randomized into two groups. One is two drugs. It was hydrochlorothiazide, a drug we still use today, and reserpine. And the other group got placebo. They're followed forward in time for about 1.5 years. That's not a very long follow-up at all. And at the end, we're going to consider outcomes. And we'll consider outcomes in the placebo group, which had 73 patients, and the treatment group, which had 70 patients. So it's a small study. Deaths. There were 4 deaths in the placebo group. There were none in the treatment group. There were 4 strokes in the placebo group. There was 1 in the treatment group. There were 4 cases of heart failure in the placebo group. None in the treatment group. 2 heart attacks in the placebo group. None in the treatment group. 3 cases of renal failure in the placebo group, none in the treatment group. 7 retinal hemorrhages in the placebo group, none in the treatment group. 3 patients were hospitalized for uncontrolled hypertension in the placebo group, none in the treatment group. Treatment complications, well, there were none in the placebo group. That's good. There shouldn't be any treatment complications. How many in the 2 drug group? Only 1. I'll do the math for you. That's a total of 27 events we'd all care about, among 73 patients versus 2. We don't see studies like this much anymore. Come on, a year and a half, 150 patients. You know what I like about a study like this? You don't even need a statistician. Flip a coin 29 times, how often does it come up 27 times? Not very often. P less than 0.001. It's a huge effect. It's a really important effect. Now, I wanted to come back to this pass a test of outpatient compliance. Would patients take their medicine? The investigators were really careful about this. Before patients were randomized, they were given 2 placebos, one of which makes the urine fluoresce, riboflavin. They were seen twice in follow-up to count pills to make sure people were taking their pills and to test their urine to make sure it fluoresced. Nearly half failed.
Did people know they were taking
They were just taking this test and half failed. And for context, today's trials, this number would be close to 90-95%. What was so different? Because this was a new thing, to take a medicine when you felt well, when you were asymptomatic. Prior to this, people didn't take medicines when they felt well. They only took medicines when they felt sick. And that's why I say hypertension marks the beginning of intervention on asymptomatic patients. It was a good thing. I'm glad we're doing this. But it started a new era in medical care. Now, what happens? Well, we change the rules. What constitutes hypertension? And by changing the rules, I mean lowering the diagnostic treatment threshold, the trigger at which we decide to intervene. When I was in medical school, the definition of high blood pressure was a diastolic blood pressure greater than 100. We said nothing about the systolic blood pressure, the top number. Maybe we didn't even know it existed. I mean, it was so long ago. I don't know. Well, now we say anything over 140 over 90 is hypertension. And doctors are getting reports like this. This is what I'm getting from the VA on their profile, the patients they're caring for, thanks to the electronic medical record, about who has high blood pressure. And I get notifications on patients who have blood pressures higher than 160 over 100. That's great. I'm really glad to know about that. But then I get some more moderate numbers. You can't really see them. I'll show them to you. 142 over 64 in a 78-year-old male. Am I supposed to do something about that? Here's another one, 144 over 68. Tell you a little bit about this gentleman. He's 82 years old. He lives alone in Vermont. He's miles from the nearest neighbor. He likes to work outdoors. He builds stone walls. He taps trees. He clears brush. He uses a chainsaw, and he's already fallen because of blood pressure therapy. And I'm supposed to treat this? Are you kidding me? The views expressed here do not necessarily represent the views of the department. I think a lot of good things are happening in the electronic medical record, but we have to be really careful that we don't set up performance measurement measures that start getting physicians to do the wrong thing, to feel compelled to treat patients. Why do I say that? Because we know something about the effect of treatment across the spectrum of diastolic hypertension. We know it from randomized trials. Here's a severely elevated, this is the VA cooperative study, 115 to 129. A moderately elevated, the bottom number 105 to 114. Mild, 190 to 104. Very mild, 90 to 99. There's some overlap there because that's what the data are. But I consider that the spectrum of abnormality. How high is your blood pressure? On the y-axis, I'll put the annual rate of death or end organ damage. Those are those same outcomes I showed you for the VA cooperative study. That's why I went through them. Things we care about, things like heart attacks, death, stroke, renal failure. Now, this is the event rate in the control group, the people receiving placebo. Not surprisingly, who's most likely to have a stroke, heart attack, or die? Someone with really, really high blood pressure. If you have moderately high blood pressure, you have less of a chance. Mild, you have less of a chance. Very mild, less of a chance. So how about the intervention arm? Here's the treatment arm. And you might say, why aren't they all at the same level? Well, because they're real data. They bounce around a little bit. But the benefit of treatment is the difference between the two bars, the so-called absolute risk reduction. And that's that difference. And I'll take away the two bars, and maybe this is a long run for a short slide, but who stands to benefit a lot from treatment of high blood pressure? People with really high blood pressure. And then it falls as the blood pressure falls. Well, let's consider this now in a schematic. The spectrum of abnormality of mild to severe, from borderline hypertension to severe hypertension. All I'm saying is the benefit of treatment steeply rises with that spectrum of abnormality. The people who benefit are the people with really severe hypertension. Now, I said at the outset, all of our treatments have harm. And so I have to have some harm curve up here. So I'll just start by drawing it here. And someone might look at this and say, well, why is it upsloping? Maybe it should have a negative slope. Maybe it should be like this, because who's most likely to fall? Because their blood pressure is made too low? Someone whose blood pressure isn't that high to start with. But regardless of exactly where we draw the treatment harm curve, the main argument I would make here is harm is not so tightly related to the spectrum of abnormality. It's more a fixed effect of treatment. It's not tightly related to the spectrum of abnormality. The curve's going to be flatter. And if that's true, the curves are going to cross at some point. Certainly there'll be an area of net benefit where benefit exceeds the harm. But there's also a possibility of an area where there's net harm, where the harms exceed the benefit. So let's come back to this. This is a performance measurement, seeing how doctors are doing in lowering blood pressure. And in diabetic patients, we're very aggressive about lowering blood pressure. And JNC7, that's our major guideline for treating high blood pressure, suggested in their 7th iteration that we should try to get systolic blood pressures less than 130. And the American Diabetes Association said there's no threshold value for blood pressure. None? Shall we take it to 0? Now, I want to come back to this issue. So we're talking about lowering the trigger for which we treat people, lowering the point at which we intervene. And I put a second curve up here, the number of affected individuals. Because as we go down this spectrum, let's say we're treating people for systolic blood pressures of 140. We treat so many people. But if we move to 120, we're going to treat a whole new category of people. And it's a lot more people. That curve rises quite steeply. So a person who is at, say, 130 used to not be intervened on, all of a sudden is intervened on. Who is that new patient? It's the patient who stands the least to gain and is arguably at the highest risk for net harm, at least theoretically. Is there any truth to this? Is there any real data? Well, here's a study called the INVEST study, the International Verapamil SR Trandolapril study. Everybody see where the INVEST comes from? All right, let me walk you through it. It's INVEST. Isn't that crazy? We spend so much effort on these acronyms. I showed this to an audience at Dartmouth, and a Massachusetts General, an interventional cardiologist said, Gil, I can beat that. Look at this, INSANIT. He was pretty sharp. He just read that. I don't know. If you guys come up with anything better, let me know, because it's a perfectly good. It's a stupid acronym. It's a perfectly good study. It's in patients with diabetes and coronary artery disease. That's a group at high risk for bad things to happen to them. And they were asking the question, how does all-cause mortality relate to the level of blood pressure? Death for any reason. The referent group is a systolic blood pressure of 125 to 130. If you lowered it down to 120 to 125, all-cause mortality is just about the same. 115 to 120 goes up a little bit, but you can see the error bars. That could be statistical noise. 110 over 115, whoa, well, that's about a 60% increase in all-cause mortality. Not quite statistically significant, the p-value of 0.07. Less than 110, now you're over twofold increase in all-cause mortality, and it's statistically significant. I don't know why we need to do studies like this. Of course, it's not good to have a blood pressure that's too low. And then we saw this, which is remarkable for me to report to you. Is last year at this time, a little over a year ago, there were new diabetes guidelines which eased the systolic blood pressure target. And I think we're in the midst of a course correction here, where all of a sudden we're saying, whoa, maybe we've been telling people to push blood pressure too low. They move from less than 130 back up to less than 140 for diabetic patients. And then, as some of you know, just a few months ago, hypertension guidelines can be eased for everybody. For patients over 60, the blood pressure guideline was eased from less than 140 back up to less than 150. I think that's a good thing. I think we're beginning to recalibrate and make a course correction on this. It's not just hypertension, though, that we changed the rules on. When I was in medical school, the definition of diabetes was a fasting blood sugar greater than 140. And then overnight it changed to a fasting blood sugar less than 126. And when I was in residency, our goal was to make diabetics to have a hemoglobin A1C, which is an average blood sugar over the last 2 or 3 months. We were shooting between 7 and 8%. And then someone said, no, wait a second, we should try to make them normal, make them like other patients, less than 6%. Now, what happens? Well, that means there's a whole new category of people to treat, right? There are people who say are 6.5%, all of a sudden it's now a patient that needs medication. That's more patient. Who are those new patients? They're the people who stand the least to gain and arguably are at the highest risk for net harm. Is good control good for patients? It's a study from the Lancet 2010. It's from the General Practitioner Database in the UK. 48,000 patients with established diagnosis of type 2 diabetes. That's the adult onset diabetes associated with being overweight. Their mean duration of diabetes is 5 years, is greater than 5 years, so they've had it for a while. They're undergoing intensification of therapy. That means more medication, either oral meds or insulin, to improve glucose control, and they need improved control. Their mean hemoglobin A1C is 9.5%. That's pretty high. So that's who's in the study. The exposure is the mean hemoglobin A1C following the intensification of therapy. This is after an average follow-up of 5 years. I like to think of that exposure as being the question, how well did the doctor do at lowering their blood sugar? The outcome is the rate of death from any cause. So let me show you the results of this. This is the exposure, mean hemoglobin A1C after the intensification of therapy, the addition of oral medicines or insulin. The outcome is the relative rate of death from all causes, and you know 1's the magic number. Anything above 1 represents increased risk of death. Anything below 1 is a decreased risk of death, and I'll color that in so you can see it. The only other thing you need to know to understand this graph is the reference category, and the reference category is 7.5. That was our old goal, right, between 7 and 8. So if you can't get a patient down to 7.5, but you get them under 9, what do you see? Well, you see maybe a little bit of an increased risk of death, although none of them is statistically significant, despite the fact there are over 200 deaths in each decile. If you can't get them down to 9, you see exactly what you expect to see. increased risk of death. It's bad to have really high levels of glucose. It's a toxic molecule. But how about down here? How about if we get them towards normal? Do we lower their risk of death? No. We increase their risk of death. And again, you wonder, why do we have to do studies like this? You know, it's not that good to have a glucose that's too low. Right? Blood pressure, glucose, those are both things we got to have. And we have to be careful not to push people too low. By the way, this was also confirmed in a randomized trial by the NHLBI, the Heart, Lung, and Blood Institute, which stopped the trial of intensive control because of an increased risk of death from all causes. We can't dial in patients' blood sugars exactly. If we get them to a normal average, that means undoubtedly at some point we're taking them too low. So it's not just hypertension and diabetes. When I was in medical school, a high cholesterol was a serum cholesterol, total cholesterol over 300. Now, having a detectable cholesterol is indication for treatment. All right, that's a little bit of an overstatement, but only a little bit. You know, it's certainly anything over 200, and I know we fractionate it. We look at LDLs and HDLs and so forth, but no one will disagree with me that our threshold to intervene on cholesterol has dropped precipitously. And osteoporosis. Osteoporosis is defined by a T-score. It's basically an X-ray of a bone looking for bone density, and the old definition of osteoporosis was a T-score less than minus 2.5, and I apologize for negative numbers and decimals. And then overnight it was changed to a T-score less than minus 2.0. Now you might reasonably ask, well, how much does that matter? You know, 0.5 on a T-score. How much does any of this matter? So my colleagues and I have looked at this in the NHANES data, which gives us the distribution of biologic variables for Americans. That hypertension change affects roughly 13 million Americans. That change put 13 million Americans as having hypertension. And diabetes, it was about 2 million Americans. The high cholesterol definitional changes affected about 42 million Americans. And that osteoporosis definition that only applies to women literally turned 7 million women into having the disease overnight. That's changing the rules. And I've worked with examples that have numbers because you can easily see how the rules change. But the rules also change in diseases that have somewhat more complex definitions. And then we're able to see more. This is a chest X-ray. This is how we used to diagnose lung cancer. So it's looking at your chest like this. That's a lung field. That's a heart field. That shouldn't be there. That's a big lung cancer. It's about 10 centimeters in size. How do we diagnose lung cancer today? Well, largely it's using a spiral CT. This is an image of one lobe of the lung. It's been enlarged. That's a small peripheral lung cancer. It's about 1 centimeter in size. You could not see this on this. Lower limit of resolution of a chest X-ray is probably about 3 centimeters. The one thing we know is there are a lot more of these than there are of those. This is a barium enema. This is how we used to diagnose colon cancer. Everybody see where the abnormality is? There's a big hint there. It's the first thing you learn in medical school. The abnormality is where the arrow is. It's a filling defect. There's barium in the colon, and it's not filling. I'll fill it in for you. That's a big polyp. It's about 10 centimeters in size. That's how we used to diagnose colon cancer. How do we do it now? Well, this is a colonoscopy image. This is a polyp about 1 centimeter in size. This is the virtual colonoscopy image of the same polyp. It's also 1 centimeter in size. And again, the one thing we know is there are a lot more of these than there are of those. And by the way, my gastroenterology colleagues are removing polyps much smaller than 1 centimeter, 0.5, 8.3. They're even talking about flat polyps, which is more than I can make sense of. This is a mammogram. It's a very old technology. It's basically a plain film x-ray of the breast. This is from about the 1960s or 70s. We'd say it's archaic and primitive, but it can sure show you a 2-centimeter breast cancer. This is a modern digital mammogram. Everybody see the abnormality? Kind of hard to see. I'll blow it up for you. It's literally pixels in size. It's about 0.02 centimeters. They're microcalcifications associated with the earliest form of breast cancer, the form that some pathologists wish they never attached the word carcinoma to, ductal carcinoma in situ. Again, there are many more of these than there are of those. So what does it mean for us to be able to see so much more? Here we're not changing the rules, the technologies are changing the rules. Well, let me ask you this question. How many lakes are there in the state of Utah? Okay, now, when I'm in New England, I have to do this. Maybe I have to do this here. Okay, that's Utah. How many lakes do you see? One. What is it? Who's been in it? All right, yeah. There's one. One big lake. But the minute you zoom into the state level view, what do you see? Oh my gosh, there's more than one lake. There's the Great Salt Lake to the northwest of Salt Lake City, but there's also Utah Lake down by Provo, and my personal favorite, Bear Lake up on the Idaho border. Every other blue spot you see there is a reservoir. But some of you may have been in this mountain range. It's the High Uinta, a major east-west mountain range in the United States. Let's just zoom into one 6-mile area of the High Uinta. How many lakes do you see? Well, it's kind of hard to see in this light, but there are just a whole lot of them. Some of them have fish in them. It's just a lot of lakes. So, how many lakes are there in the state of Utah? Well, at the continental view, there's one. You go down the state level view, there are 3. And you go down to one 6 by 3 mile satellite image in the High Uintas, and you've got 40 easily. So how many lakes are there in the state of Utah? Well, the answer depends on the resolution of the map. Right? It's totally dependent on the resolution of the map. And here I'm shamelessly borrowing from a fractal geometry, what's his name?
Mandelbrot.
Is that right? The British guy. And he was talking about how many islands are there around the British coast, and he's making the same basic point. The one thing you know is that as you are able to see more, you find more, but the typical lake gets a lot smaller and a lot less important. Now, what does this have to do with medicine? Well, I think of this as the history and physical exam. These are the presenting complaints and signs that patients present with. The Utah view is the chest x-ray, and the High Uinta is the spiral CT. We're just seeing more. We can see more. How many people have had a stroke? This is an amazing study. This is from the Framingham Heart Study, which many of you know is the major study that sort of taught us about high blood pressure and cholesterol and smoking as being major risk factors for cardiovascular disease. And they did MRI exams on people who were normal, who had no apparent findings of a stroke. And the age 70 to 89 age group, they found that 15% of them had MRI evidence of a stroke, even though they had no symptoms of one. 60 to 69-year-olds, 10% had evidence of a stroke. In my age group, 8% had evidence of a stroke. And if you're younger than me, don't feel any better because 7% of you have a stroke. And all of a sudden you realize, well, what does it mean to have a stroke? Has the technology changed what it means? Have we just changed the definition of a lake to include a puddle? We have to begin to rethink what our language is referring to. Is it referring to the classic finding of a stroke, of some neurologic deficit, difficulty walking, swallowing, etc.? Or is it talking about some MRI detected abnormality? It's different. And then we look harder. At Dartmouth, we do a lot of work with the Medicare data, and this is the number of Medicare exams from 1990 to 2006. And the number of brain CTs literally doubled over that period. This is on their constant denominator, about 30 million Medicare beneficiaries. Number of abdominal CTs went up threefold. The number of chest CTs went up fivefold. And the number of brain spine MRIs went up fivefold. We're just doing a lot more imaging. And then we encourage the well to get examined to determine if they are not, in fact, sick. We encourage the well to get examined to determine if they are not, in fact, sick. What am I talking about? I heard it. Screening, yeah. Now, this is the kind of thing that can really raise my blood pressure. It's a very attractive image. I like the advertising. You know, it's sort of done with pencils and this. I like the palette of the yellows and so forth and the script, and I'll read it to you. It won't happen to me. I go to the gym every morning. I walk to the office, and I don't let work stress me out. Young woman doing all the right things. And down here you see the tagline, Alicia Fox, 21, the day before she was diagnosed with thyroid cancer. What's that ad designed to do?
Get people to the doctor.
Get them to go to the doctor, and how's it do that?
Scare them.
By scaring them. That's a question we ought to ask. Is that a good thing for a healthcare system to do? It goes on, in case you missed the message. Confidence kills. Now that's a good public health message, isn't it? That's the thing we need to get out there. If you feel good, all hell's about to break loose. It goes on to say, thyroid cancer doesn't care how healthy you are. It can happen to anyone, including you. That's why it's the fastest growing cancer in the United States. It doesn't even make sense, does it? Thyroid cancer doesn't care how healthy you are. It can happen to you, including. That's why it's fast. It doesn't make sense. And then it says, ask your doctor to check your neck. And then it hit me. Oh, it's an editing problem. The copy editing didn't quite go right. If we switch it around, let's try that. Thyroid cancer doesn't care how healthy you are. It can happen to anyone, including you. Ask your doctor to check your neck. That's why it's the fastest cancer in the world. Right? What's happening in thyroid cancer? Next series of slides are all going to be SEER data. That's the federal government's major effort to track cancer incidence and mortality in this country. We'll go from 1975 to 2005, and on the y-axis we'll put the rate per 100,000 people. And this is what's happened to thyroid cancer incidence, the rate of new diagnoses. It's pretty stable till about 1990, and then it doubled. As we were palpating more necks, doing more ultrasounds, doing CTs, and a bunch of other things. Now, if this were a true epidemic of disease, a true change in the burden of disease, what would I expect to see happen to the mortality rate? Well, I'd expect it to have some change. Or maybe I'd expect it to start going up and then go down if we had some new incredible treatment that helped people live longer. But in fact, what do I see? I see the most stable mortality rate in the SEER data. Now that doesn't look like an epidemic of disease to me. That looks a lot more like an epidemic of diagnosis. And I think we have a very worrisome epidemic of thyroid cancer diagnosis going on right now. And let me just tell you that as of 2010, in the paper that is coming out, I think today or tomorrow, my colleague Louise Davies and I will talk about this is now up threefold. And it matters more to women than men. The absolute increase is much more dramatic in women. Remember, these are people who have their thyroid taken out. And taking out a thyroid is a tricky operation. I'm not saying it's the hardest operation that any doctor does, but there are nerves nearby, there are blood vessels nearby, there are small glands behind the thyroid that can be involved, and these people need lifelong thyroid replacement. It's not just, I'm going to ask you to hold your questions till the end, sorry. It's not just thyroid cancer. Here's melanoma. Stable mortality rate again, but nothing stable about its incidence rate. As more and more punch biopsies are done around the country, it's gone up about 2.5-fold. Breast cancer. Mortality rate for breast cancer is actually coming down. That's a good thing. Advent of mammography, though, led to about a 60% increase in the overall rate of breast cancer detected, and in the screening age group, it's about a doubling in new diagnoses. And then the poster child for the problem, prostate cancer. Fairly stable up and down mortality rate, nothing subtle about its incidence rate. Now, by the way, we don't see a lot of curves like this in cancer epidemiology. It's a pretty unusual curve, although it does track the NASDAQ very well over the period. It's just a funny curve. And I submit to you that no matter how much cancer biology you know, you cannot explain that curve unless you know what's happening in the healthcare system. It's a system effect. It's about the observers and what they're doing. Now, I've always been clear, screening has benefits and harms. And I'll give you my best sense of the deal for screening mammography right now. Among 1,000 women age 50 undergoing annual mammography for 10 years in this country, there are some benefits and some harms. The benefit is somewhere between 0.3 and 3.2 out of that 1,000 will avoid a breast cancer death. I know that's a broader range than most people would like. The 0.3 assumes about a 5% reduction in mortality. The 3.2 is the highest ever observed in a randomized trial, about 40%. The harms in this country, annual mammography, 490 to 670 will have at least one false alarm. Those data come from the mammographers themselves. 70 to 100 of whom will undergo a biopsy before that's put to rest. Some will never have the issue put to rest. They will be told they don't have cancer, but they are abnormal. They are at high risk. They have atypia. They have dysplasia. And somewhere between 3 and 14 will be overdiagnosed and treated needlessly with surgery, radiation, and chemotherapy for a cancer that was never destined to become clinically evident. Now, there's no right answer here except to tell people the benefits and the harms. Now, there is one thing that I think we should ask ourselves. Does it make any sense that ensuring all women do this has become one of the most prominent measures of healthcare system performance? Is this the way we want to judge? Is this the procedure we want to judge the quality of our healthcare system on? Now, let's take away the false positive problem. Some would say, well, maybe that's not too big a deal, and talk about the overdiagnosis harm relative to the mortality benefit. It's somewhere in the order of a ratio of 1 to 2 to 1 to 25. That's for breast cancer screening. Prostate cancer screening, the deal's worse. It's on the order of 1 to 30 or 1 to 100. Now, looking at these numbers, we can ask ourselves the question, what does it mean to be a prostate or breast cancer survivor following screening? You all have heard the survivor stories. They're some of the most powerful stories in the media, people who attribute their life to screening. Well, the standard interpretation was his or her life was saved by screening. But you can see that the logical interpretation is he or she was actually more likely to have been overdiagnosed. Now, survivor stories drive screening towards more overdiagnosis. This is the real conundrum for us. The more intensively we screen, the harder we look for abnormalities, the more overdiagnosis that occurs. The more overdiagnosis that occurs, the more survivor stories there are. The more likely it is people have read a survivor story or, more powerfully, know someone who's a survivor. That makes screening appear all the more useful, which feeds back to more intensive screening. And that's been dubbed the popularity paradox of screening. Ironically, the harder we look, The more overdiagnosis that occurs, the more popular screening becomes. And then we stumble onto things. We're doing all these images, all this testing, and we're looking for X, but we find Y. We're looking to the left and we see something over on the right. And we have a name for this. We call them incidentalomas. It refers to incidental detection. Now here's a powerful anecdote you don't often hear that I was told by a physician in Boston who was telling about his father's care. An 85-year-old man who reports excellent health goes in for an annual physical. His doctor performs a careful physical exam and thinks he feels an abdominal aortic aneurysm right in his belly. He orders an ultrasound. The ultrasound shows the aorta is normal, but suggests there might be a mass in the pancreas, so a CT of the abdomen is recommended. The CT shows a normal pancreas, but also shows a liver nodule, and a needle biopsy is recommended. Needle biopsy shows a hemangioma, a collection of blood vessels, and makes it bleed. The patient requires a week of hospitalization, 6 to 8 units of blood, and develops urinary retention following narcotics for pain. Now, this man could have died. He did not die. But the total cost of his annual physical was $50,000. Now, it's hard to find an error here. Instead, the cascade of events was all intended to help avoid a future problem, particularly cancer. The word cancer can drive everybody into a series of steps to a place we'd rather not be. But simply finding out whether the cancer is even present produces some harm, just figuring that out. And even if a cancer is present, it's much more likely to represent overdiagnosis than a deadly cancer. And even if it is a deadly cancer, the chance we just happen to stumble on it at just the right time when we can make a difference is extraordinarily low. And that's why I say incidentalomas have become a huge problem for American medicine. The more we image, the more likely we are to be distracted by something that has nothing to do with the problem that led to the request for the imaging test. Now, why do I say that the cancer is so likely to be overdiagnosis? Because we had this period about 6-8 years ago where there was a flurry of interest in whole body CT screening. And we have some data. This is from about 1,200 asymptomatic volunteers. They're age 54. They're healthy. They're wealthy. They could all afford a $1,000 test at the time, which was not covered by insurance. And 86% of the population had at least one abnormality. The average patient scanned had 2.8 abnormalities. There's a vast reservoir of abnormalities, most of which are not going to be relevant. By the way, one more of these slides. This is renal cell carcinoma, cancer of the kidney. Its mortality rate is stable. Its incidence rate has also doubled. No one's screening for this disease. We're stumbling onto it. We're stumbling onto it as we do more and more abdominal CTs. So how do we move forward? This has been a big shift of paradigms over my career. The old paradigm was making diagnoses in patients who are experiencing problems. The new paradigm was to seek diagnoses in patients who are not experiencing problems. That's the idea of early diagnosis. Now, I want to be clear, the paradigm of early diagnosis is not always wrong. We'd much rather repair a deep laceration of the skin soon after it occurs than wait till infection sets in. We'd rather see patients early in the course of their pneumonia than wait till they develop shortness of breath and gross infection. We'd rather see patients early in the course of their heart attack than wait till they develop arrhythmias and hypotension, too low blood pressure. And we'd rather see women with a small breast lump than to see them when they have a large breast mass. The question is, how often should we get ahead of symptoms? In the past, we treated a population. We didn't really think of it as a population, but we waited for problems to develop, and then we made our diagnoses and treatment in the fraction that developed problems. The early diagnosis ideal was to take that same population and through early diagnosis advance in time to the point we could make the diagnosis and treatment, with the assumption being that the natural history, that if you didn't do anything else, these were the people who were destined to develop problems. That was the ideal of early diagnosis. But the reality is, whenever we look early, we find more patients with the abnormalities. Now, the natural history is more complex. Hopefully, we've got those that are destined to develop problems, although we may miss some, particularly for the worst problems tend to grow very fast. But we also have diagnosed a new fraction, those not destined to develop problems. They're the overdiagnosed and needlessly treated group. I want to be clear, nothing good can happen to this group. There's nothing to fix here. All experience the impact of diagnosis. That's the impact of being labeled as being sick or having some abnormality, that vulnerability, you're not healthy. And in this country, before the ACA, it affects your insurance. Hopefully that's really in the midst of being changed. But people lost insurance or had to change carriers or had to pay a lot more simply because of a diagnosis. Most experience the impact of intervention, the so-called hassle factor, subsequent appointments, more testing, surveillance, phone calls, filling scripts, filling out insurance forms. And some experience harm from the intervention, medication side effects, surgical complications, even death. How did we get here? Or a quintessential American question, who is to blame? And if you remember my generation, this guy always comes up as a reasonable candidate. This is Richard Mulhouse Nixon, and unbelievably, it works pretty well here. Dick Nixon said, we need to work out a system that includes a greater emphasis on preventive care. This was a large part of the Health Maintenance Organization Act in 1973. It was also a big part of the War on Cancer in 1971. And what we have here, I think, is a failure to understand exactly what is meant by preventive care. A failure to distinguish between two very different types of prevention. I think of preventive medicine as involving two things, health promotion and early diagnosis. They're very different. Early diagnosis is what a test might tell you. And I liken it to this light here. This is my 1999 Volvo. Let me just, you guys know that thing? Now, even though this car is a 16-year-old vehicle, even back then it was testing about 200 different systems on the car. And my light's at the point where it's coming on quite a bit. In fact, this is the dashboard right now. You know, the car's driving fine, but these lights are coming on all the time. That's early diagnosis. And this is my wife's Subaru, which is a newer car, a 2006. And it's kind of interesting. It has a check engine light too, but it has a new feature. When the check engine light comes on, the cruise control light starts flashing. You know that? You have a Subaru? It's unbelievable, isn't it? So you got a problem on like your admissions or all of a sudden, and you don't have any cruise control, right? It's pretty clever, right? We ought to learn something from the Subaru engineers. Why do they do that? Why do they take your cruise control away when something else is wrong with your car? Yeah, they want you to make you do something. We need to learn from them. If you're not going to get your mammogram, I'm going to stop treating your really high blood pressure. I mean, that's what we should do. And it's easy to laugh, except some women have been kicked out of practices just for this reason. Why? Because the doctors are being measured on it because we presume it's always good for everyone to do. That's a little crazy. Early diagnosis is what a test might tell you. Health promotion is what your grandmother would have told you. Now, this isn't the most flattering picture of me in Vermont, but this is what I think of as health promotion for your vehicle. It's changing your oil. It's keeping your tire pressures up. Do you do that? Good. And wash the salt off the car after the winter. I don't know, do they use salt around here? No? Oh, no, we're in Washington. Yeah, okay. Well, we use salt. What would your grandmother have told you about health? She would tell you, get plenty of sleep, eat your fruits and vegetables, go play outside, and don't start smoking. And you know what? That's pretty important information. It's simple. It's not high tech. It's not very complex. Maybe it doesn't need to involve doctors, but it's really important. The basic idea is really positive. It's about being healthy. Well, the basic idea here is not so positive. It's looking hard for things to be wrong. And the question I'd like to leave you with this afternoon is, is looking hard for things to be wrong a good thing for a healthcare system to do? Because health is more than a physical state of being. If we let health be defined as the absence of any abnormality, we're all destined to be sick. Health is also a state of mind, and we have to be really careful that we don't undermine that state of mind, because that's a very central part of health. IBM would like to have you alert doctors before patients get sick. They see this as smarter health care for a smarter planet. But I wonder, is this a recipe for a sicker planet? Thank you very much for your attention. I'd be happy to answer any questions. Did you want to say?
We only have a few minutes, so if there's someone with a really burning question, you should get it in now.
Dr. Greenberg.
It's not burning. Your examples are really taken from a medical care system with an abundance, maybe an overabundance of resources.
Yep.
Could you extend your thinking of these effects to situations where resources are scarce? Because certainly screening is being introduced in a very poorly planned way to many very low-income countries.
I think it's a great question, and one of my questions is, why am I here? And I think there's probably two answers to that question. I'm going to guess there's two answers to that question. Is one, I think all of you that think about the countries that don't have as many resources, we have to make sure we export good ideas from American medicine, not ideas that make more people sick. And I think that's an idea that is probably useful for all of you to think about. That just everything that's supposedly great may not be great. And that too much medical care can be harmful for people. So I think that's one important idea. I think the other important idea is to be very sensitive to how your measures of disease burden can be influenced by the healthcare system itself. It's one of the reasons I showed you those incidence and mortality curves. These are things where the underlying burden of disease are largely fairly stable, but our recognition or our labeling of who has the disease has changed dramatically. And I think that's something you need to think about as you're thinking about global health measures. So I think those are the two things I would take from this talk. Yes, sir.
One more question. You didn't mention colorectal cancer screening.
Yeah. I didn't, because the problem of overdiagnosis is not as evident there at the stage of cancer. As you may know, incidence rates of colon cancer have been falling actually long before we started screening for colorectal cancer in this country. It peaked in about 84. So something is going on that's good there. The overdiagnosis that occurs in colorectal cancer screening isn't at the cancer diagnosis stage, it's at the polyp stage. And probably about a third to a half of the population, about right, will have some polyps, something like that. Other questions?
I have a question.
Yes, please.
I'm an internist, like you said, but I train with those guidelines, and I've seen like a trend of them, and they have not incorporated something that is coming, that is high throughput technology, specifically genomic technologies, and there's a lot of information coming from this that might have an impact on screening. How do you see that paradox where you have more information that should be good, but on the other hand, that might lead to overdiagnosis?
Right. Well, I think the genetic story is actually a pretty interesting one. I think there's a lot of hope that genetics would clear all this up, and the truth is it hasn't. And the reality is that we're a complex interaction of genes and environment. And I think that while there's some powerful genetic information, a lot of that we knew about before we could even read the DNA, right? Because it was so obvious. We knew there was something like a breast cancer gene long before we could read BRCA1 or BRCA2. Why? Because it was so powerful in families. But I don't think there's a lot more of that sort of low-hanging fruit around that where we're going to, things that where we're going to find just obviously powerful genetic markers because we would have seen them already without the genome. I think we're going to get a lot of sort of small risk adjustment information. By the way, this is a little bit separate than trying to characterize a tumor's genome, which is a little bit different than the human one. But I think largely this has led to hopes that were not really realized, that there's too many complex interactions for this to be that useful clinically. It's only in certain conditions where it really is.
Well, let's thank our speaker again.